Hi guys, if you're just joining us, it's Dr. Mo here from Inspire Medics. We'll get started in a couple of minutes. We're just waiting for everybody to join. You're joining the AKT/RCA/MSRA, slight typo there, teaching on ectopic pregnancies and cataracts. This will be a 1-hour session. We'll be covering 2 topics. We'll be summarizing the latest NICE guidelines for you. If you're just joining us, it'd be good if you could let us know where you're joining us from in the UK, and also if you're sitting any relevant exams very, very soon. So for example, the AKT, the RCA, or the MSRA. We will get started in a few minutes. We are going to live stream this to our Facebook groups as well. And we're also going to record this webinar so that it's accessible later on, should you wish to watch it back. And of course, this is an interactive session, which means that you can ask questions. There's a Q&A icon at the bottom of Zoom. If you click on it, you can type in your questions and we can get those answered later on. So welcome to this live webinar, which is done by Inspire Medics, Dr. Sandhu and Dr. Mo. We will get started in a few minutes. We're just waiting for a couple of people to join. As soon as Dr. Sandhu is here, I'm going to live stream this to the Facebook groups. And for those of you who are not aware of which topic we're covering or you've forgotten, it is ectopic pregnancies and cataracts. So now that Dr. Sandhu is here, I'm going to actually live stream this to Facebook. Vikas, if you want to do any shout outs, for example, about tomorrow's mock exam, or about the session today, or about where everyone's joining us from, now will be a good time to do it.
Yeah, absolutely. So welcome, guys. So slightly different today because obviously we've got a bit of a change of schedule. So I can see that people are starting to join. So welcome to your kind of AKT, RCA and MSRA preparation webinar. Obviously, we'll give you a shout out if you let us know where you are. We are on Saturday evening. It's normally a Sunday evening slot, but we do have the full day AKT mock exam tomorrow, which has already got a huge turnout. There are some last minute spaces. If anybody does want to join, do let us know. It's a live exam, so 3 hours in the morning, followed by an hour lunch break. And then it's going to be full on teaching with me and Dr. Mo, going through hundreds of nice CKS topics, quick whistle stop tour, but very full on day, very useful for the last cohort. So obviously do join us if you're there. I know that we've got a couple of people. So Muhammad Ali from Birmingham. I wonder if this is Muhammad Ali, your friend, Dr. Mo, or whether this is another Muhammad Ali. Welcome, guys. So I can see that people are trickling in now. We actually have got a medical school webinar as well after this. So it's a free webinar for college students and graduate students who want to go into medical school. So we're going to be obviously conscious of time. So I think what we probably should do, Dr. Mo, is probably get started actually. So I'll probably let you go first. You're going to talk about ectopic pregnancy, and I will then talk about cataracts based on the current NICE guidance. And obviously people are joining as they go along. If you're joining us from the AKT Inspire Medics Facebook group, then welcome. You can always type into the box, and we can see what questions you've got. And obviously we will leave this webinar in the Inspire Medics Facebook group, and we'll also put it on our YouTube channel on Monday. So over to you then, Mo.
Absolutely. So guys, just going to make sure that you can see the screen okay. So if you can see me and hear me, quick show of hands, just raise your hand. There's a button in Zoom. This is live. Thank you, Mohammed. This is live streaming to Facebook as well now, and the webinar is being recorded. Mahwash, thank you so much. So let's get started. There's quite a lot of information to cover today. We are going to try and summarize it so that it's easily digestible, it's easily remembered for the exams. Of course, will allow you to then go on past the relevant exam that you're sitting, if it's the AKT, the RCA, or the MSRA. So this is an outline. We'll go through the latest guidelines for ectopic pregnancies from NICE. We'll then go through any Q&A that you may have. We've got an AKT big mock exam tomorrow, very competitively priced at $99.99. It's a full day mock, 3 hours. For the mock, and then we do 6 hours of teaching after a 1-hour lunch break, and it's all done on Zoom. You can do it from home because of the COVID situation. Dr. Sandhu will then talk a bit about cataracts and the latest NICE guidelines for that specific ophthalmology topic, and then obviously a Q&A, and we'll give you an insight into some new features that have recently been launched on the Inspire Medics website. So let's do a quick recap. I know some of you are still joining. If you're still joining, don't worry, you haven't missed much, but we're going to recap ectopic pregnancies in terms of the knowledge base that you should already have, and then of course the most relevant information. with regards to guidelines. So an ectopic pregnancy is basically a pregnancy that lies or implants outside of the uterine cavity. And approximately 90 to 95%, so the majority, end up in the fallopian tubes. On this diagram, you can see some places where the ectopic pregnancy may implant in other locations. So for example, it could be a C-section scar if there's been a previous cesarean, it could be in the cervical region, it could even be in the abdomen. So that can also occur. But the key thing to remember is most of the time it's in the fallopian tubes in over 90 to 95% of cases. And why is that so relevant? Well, if you have a pregnancy in the incorrect place, i.e. not within the uterine cavity, you can get tubal rupture, for example, which can cause hemodynamic instability. And in the worst case scenario, it can result in death. And of course, we want to avoid that. So let's do another recap, which is what are the risk factors for ectopic pregnancy before we move on to the actual NICE guidelines and the latest NICE guidelines. So there are a couple of risk factors you need to be aware of. In about a third of ectopic pregnancies, there's no known cause or risk factor. But for the other 2/3, 66% or so, there are known risk factors. And these are things you want to be screening for when you're perhaps querying a ectopic pregnancy in a female. So obviously, a previous history of an ectopic can increase your risk of a current ectopic, pelvic inflammatory disease that can occur post-STD infection, for example, IVF, so in vitro fertilization, previous history of surgery, specifically in the abdominal or pelvic area, smoking is a risk factor, age is a risk factor as well. Age over 35 years is classically when it becomes a risk factor. Having multiple sexual partners, now this may tie into the fact that there's an increased risk of STDs, which is why it's become a risk factor in its own right. And then the other interesting risk factor to be aware of, which may come up as an AKT question, is contraceptive failure. So let's just talk a bit about that. Overall, if you use contraception, it decreases your risk or decreases the incidence of having a pregnancy. So overall, most contraceptives, all contraceptives, reduce the risk of pregnancy. Thereby, by default, they decrease the risk of having an ectopic pregnancy. However, if you do have an ectopic pregnancy whilst on a contraceptive, it's more likely to occur with the following 3 contraceptive methods, and that's IUD, intrauterine devices, that could be the Mirena or the copper coil, the progesterone-only pill, and sterilization. So with the combined pill, for example, or emergency contraception or condoms, even if you have contraceptive failure, your general risk of developing ectopic pregnancy on those contraceptive methods is as equal as the general population. So what is the risk in the general population of developing an ectopic? Worldwide, the risk is 1 to 2%. If you look at the UK studies, anywhere between 2-3% up to about 10, 15, 20%, depending on which study you look at. But of course, it's important to know about the relevant risk factors. And as I said, contraceptive failure is more common with IUDs, progesterone-only pills, and sterilization as a risk factor for developing an ectopic pregnancy. And that could be an AKT question. Right, so I can see about 23 of you have now joined. Welcome. If you've just joined, you haven't missed much. Now we're actually going to go into the actual guidelines for ectopic pregnancies, things that you must know. We've done a recap in the last 5 minutes or so. So when should you suspect an ectopic pregnancy? Now, the obvious one is, of course, female of childbearing age. Sometimes we have a question about how about a woman who's had a hysterectomy? Is it possible for them to have a ectopic pregnancy? And the short answer is yes. It's very, very rare. So a woman can have a hysterectomy. The ovaries are preserved, of course, but there have been case reports in the BMJ where those women who have had a hysterectomy have gone on to develop an ectopic pregnancy. So this be vigilant. Any woman of childbearing age, even without a uterus, for example, can develop an ectopic pregnancy. Now, the most common symptoms are abdominal or pelvic pain, missed period, which should alert you to the fact that there could be a pregnancy going on here. PV bleeding, that's a relatively common symptom to develop. And then in terms of examination signs that you may have, you can have most commonly abdominal, pelvic, or adnexal tenderness on pelvic exam. So those are the ones that most commonly present to a clinic if a patient is possibly going to have an ectopic. Now, there are less common symptoms and signs, and you do need to be aware of these because The key thing to know as a good doctor, and what's expected from the General Medical Council, is of course picking up on those less common symptoms and being alerted to the fact, is this a pregnancy? Could this be an ectopic pregnancy in a young female or a female of childbearing age? And those symptoms are breast tenderness, diarrhea / vomiting, lower urinary tract symptoms. So don't always think that if a woman has dysuria and frequency, oh yes, definitely it's a suspected UTI. If she's missed a period, or she hasn't had a period, or you may want to signpost about her next period if she misses it or if it changes, to watch out for a possible ectopic pregnancy. Dizziness, fainting, syncope, those more commonly occur in hemodynamic instability when you have tubal rupture, but again, those are less common symptoms. You can also get shoulder tip pain. So if you remember from your pathophysiology, if you get, for example, bleeding inside the abdominal cavity as a result of an ectopic pregnancy, it can cause irritation of the diaphragm, which can result in shoulder tip pain. And that's the reason you can get that. So it's worth asking about that in your history. And then the other symptoms are rectal pressure or pain on bowel opening. And then also if the patient has noticed any passage of tissue, PV, in the last, for example, couple of weeks or since their last menstrual period. So those are common symptoms and less common symptoms. And those are, of course, important to watch out for. Now, if you are suspecting an ectopic pregnancy, you do want to offer a bedside investigation, and the most easiest one to do is, of course, a urinary pregnancy test. And don't forget, 2 lines means it is a pregnancy, which is a positive test, and 1 line means that that it is not a pregnancy, although sometimes you may signpost patients to repeat the pregnancy, because classically ectopic pregnancies are picked up generally at the 6 to 8 week mark from the last period. So you tend to develop symptoms 6 to 8 weeks. So these symptoms 6 to 8 in terms of an ectopic pregnancy, 6 to 8 weeks after the last period. So you may not necessarily get ectopic pregnancy symptoms in the first 0 to 6 weeks from the last period. And that's important to know, because again, it allows you to differentiate what might be going on and formulate your differential diagnosis. Now, in terms of management, NICE is very clear. There are 3 types of scenarios you're classically going to experience. One is where a patient is acutely unwell, where a female is acutely unwell, she's hemodynamically unstable, so a drop in blood pressure, tachycardic, and it's likely there's been a tubal rupture at that point in the fallopian tubes, or possibly there's been an issue or a rupture or a bleed of some sort within the abdominal / pelvic cavity. So that's relatively straightforward. It's an ambulance transfer to hospital, to the gynae team, or to the A&E department. Now, there are scenarios where you should admit a female who has a positive pregnancy test along with the symptoms, and on the same day to EPAU, so the Emergency Pregnancy Assessment Unit, but also you could admit those patients to the gynecology team directly if you spoke to the gynecology registrar, as an example. So those scenarios are if you have a patient who you suspect of having symptoms of a ectopic pregnancy, and they have any one of the following 4 scenarios. So they have abdominal pain and tenderness, they have pelvic tenderness, thirdly, they have a cervical motion tenderness, so on a pelvic examination. Or if they don't have any of those symptoms, but you suspect a ectopic pregnancy, and they're over 6 weeks in terms of their last menstrual period, or you're uncertain what the gestation is because a woman's forgotten when her last menstrual period is. All of those scenarios, if the urinary pregnancy test is positive, you would refer into EPAU. And the reason for that is, of course, you want the female needs to be investigated whether or not this is a possible ectopic pregnancy, and then managed. So just to recap the last couple of slides, common symptoms and less common symptoms for a ectopic pregnancy, which should then prompt you to do a pregnancy test, which, if it's positive, should allow you to then decide what the next step in management is. So do you get an ambulance transfer for hemodynamic instability? Do you admit them if they have abdo, pelvic, or cervical motion tenderness? Remember, with abdo pain, they must have 2 of the features together. So they must have abdo pain and tenderness, and that's when you admit to EPAU. Or are they 6 weeks or more since their last period, and they have an uncertain gestation, but they have a positive pregnancy test and some symptoms which may be indicative of an ectopic pregnancy, which may include, don't forget, guys, lower urinary tract symptoms. Now, once they're in the hospital, the best investigation, so this could be an AKT or an MSRA question, which is what is the best investigation for a ectopic pregnancy. You may have, for example, transabdominal ultrasound, a transpelvis ultrasound, an MRI of the abdominal/pelvic cavity. But the best investigation, which is recommended by NICE, is a transvaginal ultrasound. It allows you to give good imaging of any possible ectopic pregnancies which may be in the surrounding structures. And if there's any doubt, so for example, if the beta HCG levels, if they do further bloods, beta HCG levels are low or high, or they're not sure from the transvaginal ultrasound what's quite going on in terms of if there is or isn't an ectopic, then you can usually move on to an MRI of the pelvis, which would be a safe option in a possibly pregnant female. In terms of treatment, this is more secondary care, but you should be aware of the management options. There's conservative, there's medical, and then the surgical. Of course, we all learn about this in medical school. With the conservative, the specialist may advise, okay, we'll repeat the beta HCG or the pregnancy test in 7 to 10 days, and then we'll see what happens. Because about 50% of ectopic pregnancies will naturally, spontaneously abort, and the woman would have a miscarriage. The second medical option would be methotrexate. So you give the female methotrexate as obviously as medication, and then that would induce a miscarriage in the female. And then there are surgical options like a salpingectomy, where obviously you remove you remove the actual tubes themselves. I was going to do one more slide. I think I've possibly omitted it, which was oh yeah, this one here. So let's say you have a scenario. How do you manage a female who's under 6 weeks gestation? So you suspect an ectopic pregnancy. She's got a positive pregnancy test. There's associated bleeding, which is what the NICE guidelines give the scenario for, but there's no pain. So under 6 weeks, some bleeding associated, PV bleeding, but no pain. In a scenario like that, what NICE would recommend is that you repeat the pregnancy test in 7 to 10 days. If it's positive after 10 days or 7 to 10 days, you would refer into EPAU or the gynae team. So you refer the patient into hospital, because then obviously then they'll need an ultrasound and further management. If, however, they're then negative 7 to 10 days after your original consultation, you would then have a almost Breaking Bad news type consultation with the patient, and you would explain that they're likely to have had a miscarriage. It's almost definite that they've had a miscarriage because the pregnancy test is negative. So I just want to tie that in all together before we move on to the Q's and A's, because I appreciate I've jumped about a little bit in the slides. So firstly, ectopic pregnancies are pregnancies outside of the uterine cavity. Most commonly found 90% of the time in the fallopian tubes. There are some common risk factors which you'd be aware of, although a third of ectopic pregnancies have no risk factor when you ask in the history on the actual case scenario itself with an individual patient. There are common and less common symptoms you need to be aware of, and those symptoms should alert you to the fact that the patient may be pregnant and that they may have an ectopic, which should then prompt you to do a urinary pregnancy test. And if it's positive, that needs you to act on it, which is A, do you need to admit the patient via ambulance transfer to hospital if they're hemodynamically unstable, if they have abdo pain and tenderness, or if they have pelvic tenderness or cervical motion tenderness, or there are more than 6 weeks since their last period, or if you're uncertain about their gestation, you admit them to EPAU or under the gynae team. Remember, guys, when you do the pelvic exam with these females that you suspect of having a ectopic pregnancy, please be very gentle. It's possible to cause a tubal rupture if you're not gentle during a pelvic exam. And then if the female is under 6 weeks of gestation, generally what you would recommend, and if they've had bleeding and no pain, so you would generally recommend a pregnancy test 7 to 10 days later. So of course you can send them home, they're not hemodynamically unstable, get them to repeat the pregnancy test. If it's negative, it's likely to be a miscarriage. If it's positive, they need to come back, they need to be referred, or they need to call back or attend the EPAU, because they need to be referred back into hospital under the gynae team or to the EPAU ward or department. Finally, as we covered earlier on, the best choice of investigation is a transvaginal ultrasound if you suspect a ectopic pregnancy in secondary care. And in terms of management, conservative management, methotrexate, which is medical management, and then surgical management, which can include a salpingectomy. So what we're going to do is we're just going to bounce out of this session for a moment. Just want to get a quick show of hands. So, okay, Narendra's got a question about this. Quick show of hands. How many people are sitting the AKT exam in the next 3 to 4 months? Just raise your hands. So quick show of hands if you're sitting the AKT exam in the next 3 to 4 months. So there's a button on Zoom which you can press. And if you press it, it'll allow you to raise your hand. So we have, okay, 8 people, 9 people. Okay, fine, good. Quick show of hands. How many people are going to be sitting? Connie, thank you. Connie, you just raised your hands at like the last second. How many people are sitting the RCA exam in the next 3 to 4 months? Quick show of hands. So Brian, I think we've seen you before on the RCA Advanced Communication Skills course. Okay, Oli Coyote, Uchi. 3 people sitting the RCA exam in the next 3 to 4 months. Okay, fine. And then lastly, how many people are sitting the how many people are sitting the MSRA exam in the next 3 to 4 months? There's a short window now for the MSRA exam. Okay, fine. So it looks like it's mostly AKT/RCA participants. Okay, guys, for those of you who are sitting the AKT exam in the next 3 to 4 months, highly recommended that you, if you're free tomorrow, attend the AKT Big Mock. It's excellent value for money. I know we used to previously do discounts, but we've looked at the other prices for the other companies that do AKT mocks, and they tend to price it around about 150 to 200 pounds. We price it at $99.99, which is extremely competitive. You get lots of value. You get a 3-hour mock. You then get a 1-hour lunch break, which of course you can take in your own time, but then you get 6 hours of teaching with the latest NICE guidelines, just like we've taught you today. We've summarized key points. And so you get a lot of value, you learn a lot, and most importantly, it helps to boost your AKT mark to make sure you pass. We've got 2 dates in line with the 2 AKT exam dates, which are coming up. We've got the 17th of January and the 18th of April. If you're even thinking about booking into this, don't hesitate. Like, it's so much value for what you get, and you will learn so much. So just click on the date that you want to choose, just add to cart, follow the checkout process, and you're good to go. We'll send you a Zoom link and you can attend tomorrow. I think we've already got, is it about 17, 18 people already booked in for tomorrow? Would love to see some of you on board if you're sitting your AKT exam. The other thing that we have is the RCA Advanced Communication Skills course. This is not a standard communication skills course. This is an advanced communication skills course, which I think 2 or 3 of you have already attended. Again, very competitively priced. It's a full-day course. We've got the 14th of January and the 28th of March. Very useful if you want to prep and learn about what you need to demonstrate in the videos to score the top marks. We'd highly recommend bouncing onto that link. And Dr. Sandhu is going to paste those links into the chat for you now. And then for those of you sitting the MSRA exam, we've of course got the MSRA free question bank. We've also got different packages. We've got the bronze, silver and gold package, which includes videos, podcasts, and of course flashcards that we post out to your home address. So do take a look at that. It's under MSRA at the top on the mega menu, and you get 750 videos, 750 podcasts, and we are updating those podcasts regularly. We're going to bring them in line with the latest NICE guidelines. For those of you, of course, who are doing AKT, you've got the free AKT question bank. Please don't forget that whilst the questions are free, you can subscribe to the gold package, which again has got 750 videos, 750 podcasts, and we actually send out free flashcards at the same time. This price, by the way, at the moment it's $14.99. It's going to go up. There was a pricing error we made. One of our teams who's in charge of pricing dropped the price by mistake. We're going to fix it in the next 48 hours. It should go up to $74.99. So if you want to grab yourself a bargain whilst the prices are accidentally technically low because of an error on our part, now would be the time to do it. It's where the AKT free question bank is. So what we're going to do is going to answer the questions which we have on the chat. So Uchi's got a question about how about a missed period with mild bleeding at pain but negative pregnancy test. So Uchi, what you do is you repeat the pregnancy test in 7 to 10 days, because remember the pregnancy test doesn't always become positive in the first week post ovulation. It can take anywhere between 7 to 10 days for the beta HCG levels to increase sufficiently for you to pick up on it. So yeah, absolutely, repeat the pregnancy test in 7 to 10 days will be a safe piece of advice. Okay, what we'll do, I don't think anyone else has got any other questions. Dr. Sandhu is now going to talk a bit about cataracts and talk you through the latest NICE guidelines. I'm going to disappear from your screen, but I'll catch you in about 20 minutes.
Okay, so perfect, guys. So welcome to the second strand of your GP trainee VTS webinar. So we're going to talk about the second topic, which is cataract, going through the current NICE guidance. So that's another hot topic that you can get in the bag relevant to your AKT exam and the RCA exam, which some of you will be sitting. So I know you're at different stages. So what we'll do, so you probably know the structure of my presentations now. We'll break it down, we'll take home the relevant information, keep it nice and simple and concise. We'll define it, we'll talk about the causes, the risk factors, the key features in adults and of course children, because there are differences. And of course we will talk about the management of this condition. So what is a cataract? Now a cataract essentially is an opacity. So it's a clouding, that's the best way to describe it, that forms in the lens of the eye, obviously reduces the transparency of the eyes. And it can basically affect one or both eyes, and it can occur at any age. Now, if you're doing RCA, you want to be thinking about, well, how am I going to communicate this to a patient? So you need to make sure that you've got a simple definition. So Mrs. Smith, you know, we've got your letter from the specialist, and they've said that, you know, you've got a condition called a cataract. Have you heard of this before? No, I've never heard of that. What is that? Well, basically, you have your lens, which allows you to see. What happens is over time, there's a bit of clouding that occurs over it, and that would explain the symptoms that you've had, that blurring and gradual decline in your vision. Does that make sense so far? So keep it nice and simple, and that's exactly what it is. It's a clouding that forms within the lens of the eye, and that will then go on to cause these symptoms that we're going to mention in the slides that are coming up. In terms of the causes, well, the commonest cause is aging. So as we get older, we are more likely to develop cataract. It's the commonest cause, and obviously it's more common as you go over to the age of 60. But there are other things that can trigger off a cataract. So if you've had, for example, trauma to the eye, this can be as a result of a traumatic injury or indeed an operation under the eye team. Eye disease, so sometimes people get, you know, there's acute red eyes that we know of, you know, the chronic anterior uveitis, your acute angle closure glaucomas. Then you've got other things, retinitis pigmentosa, high myopia, and you've got a few hot things here. I mean, you're very unlikely to be asked this in your AKT, but there are other things that NICE mentions, like the congenital problems, gyrate atrophy and Stickler syndrome. But again, you don't have to know these. These are just mainly for your reference. There are other systemic diseases that affect other systems, but of course they involve the eyes as well. The classic one is diabetes. We know that the eyes can be damaged with poorly controlled diabetes. There are other conditions like myotonic dystrophy and neurofibromatosis as well. And also if you've got severe dermatitis, you know, with a severe allergic reactions that could persistently affect the eye chronically over a period of time. And then, of course, you can get congenital cataracts. These, of course, tend to affect children. Then there's other things that that are kind of recognized as key risk factors for cataracts. So you can get asked this in an AKT question. And likewise, you can look at this when you're trying to build a differential diagnosis in the history of a patient for your RCA and day-to-day clinical practice. So people who've got a positive family history of age-related cataracts are more likely to go on and get it themselves. Those who take long-term steroid treatment, so you'll have patients, for example, those who've got polymyalgia rheumatica, who are on high-dose prednisolone, they may be on it for, you know, several months, maybe longer. They are also more prone to cataract, and it is something that we should be counselling patients about when we put them on long-term steroids. The third thing is smoking. So smokers, apart from obviously the risk of heart disease and COPD and various other pathology, they can also get problems with their eyes. And an interesting one, which is prolonged exposure to UVB light, is another risk factor to be mindful of. So some people who spend too much time in the sun or exposed to kind of you know, machines and so forth are the ones who are going to be more prone to developing cataracts. So this is an interesting picture, and the reason for it is because the features that adults tend to present with is actually a gradual loss of vision. So this is not an acute presentation. A cataract is a chronic history, and back in the day before the RCA, when they used to do the CSA, it was an easy case for them to have for the actors, and it's an easy one, you know, that they used to put into the exam. In terms of the RCA, of course, it will just depend largely on what you get in your day-to-day clinics, but in day-to-day clinical practice, be mindful that when you see older people with a gradual loss of vision and often painless, you need to make sure that it's not an underlying cataract. And sometimes they complain of things. So they mention things like they've got difficulty doing day-to-day tasks. So classic things like reading, recognizing faces, or issues when they're watching the television. And they tend to get this glaring kind of glare that they see when they kind of looking into a bright light. Sunshine, or if they're driving at night time when there's lots of vehicles coming towards them. A very good picture here. It's got this kind of glaring kind of image. I mean, it's just the best that I could come up with, really, but it's not a bad picture, but it gives you this kind of global glare. But really, it's like sunlight and oncoming vehicles. They tend to cause this abnormal issue in the vision of adult patients. Remember, it can affect one or both eyes. In contrast, there are subtle differences in children. So it may be that their vision is an issue and it's picked up by their parents or their carers. For example, they may not really be responsive to their toys. They may not be, they may be a bit more clumsy, not looking where they're going. But the classic thing, and this is a classic exam STEM question that you get, is that actually the parents may have taken a picture on their phone or camera, and actually they've realized that there's no red light reflex. So there's basically a white or grayish pupil. They call it a leukocoria, and that's a classic feature, and often it's picked up in that way. The other one that some children get is involuntary eye movement, so that kind of jerky nystagmus movement, and some children get a squint. So that maybe that when the eyes are not if you look at the eyes, one may be slightly malaligned. And also sometimes, they can get some of the features that we've talked about in adults, which is that kind of sensitivity to light or glaring. Obviously, some of these things become more obvious as the child gets older and they can actually communicate these changes to you. Otherwise, it'd be kind of the way they behave that gives some kind of clues to the parents. The examination features. So obviously when they're in the clinic, there's a few things that we look for. So the visual acuity is tested often with a Snellen chart, and it's always going to be, or usually, reduced on the affected side. An ophthalmoscope, remember, in a dark room, or in a reasonably, in a room itself, and you can actually see that clouding over the lens. It's a little white cloud in the middle of the eye. And then obviously the red light reflex is gone. So when you switch the light off and you try to kind of shine the light in the eye, you can see there's no red reflex there. Congenital cataract, remember, very important. So some of you may be doing this, but many of you will be doing this when you qualify as GPs, and that's the 6-week baby check. If you're doing a pediatric job, then use your time in pediatrics as a GP trainee to go and do some baby checks on the neonatal unit. I took the opportunity when I was there. It was great. There's hundreds of babies. You've got a pediatrician there as well, so they can oversee you. Obviously, you can get it signed off for your portfolio, but it's really, really good because you get to watch them do it, and then you start doing it regularly. And often, you can see how to safely examine a neonate. You can take that practice with you when you do the 6-week baby check. Now, generally speaking, the red reflex, if that was missing, that you'd expect that to be found quite early on, i.e. in the initial baby check, but it's not. It's something, something you should be looking for in your 6-week baby check, which is why we switch the light off. And when the babies settle, we try to have a look in the eye and we look to see that both red reflexes are present. If they're not, then it's an urgent referral to the ophthalmologist. So do make sure that you take those opportunities to learn. How do we manage it? So when you suspect a cataract, the first thing you do, because remember, it's not an acute red eye that needs to go to eye casualty. So it's a chronic disease. So you get them to see an optometrist, get them to have a full-on proper assessment of their visual acuity, either just without glasses, or if they obviously are wearing corrective lenses and stuff and glasses, and that should be checked with that. And obviously for babies and children, if we suspect it, then as I mentioned before, it's an urgent referral. You don't need to send them to an optician because babies need to get treatment straight away. Otherwise, it can lead to permanent damage to the eyes and their vision. We obviously then talk about the option of cataract surgery. So once they've seen the optometrist, optometrist has confirmed, look, the visual acuity is down, you know, there's a good going opacity there. They may recommend cataract surgery. And then the key thing from a doctor's side is that you obviously counsel the patient. So what you want to work out is how is that cataract affecting that patient's quality of life? What is it stopping them from doing? And that's a big marker in deciding what to do next, because patients will often say, look, it stops me from, whether it's driving or doing my day-to-day chores, doing my hobbies, doing the gardening, you know, those are the kind of things that people want to do, and they want to remain independent. The other thing is whether it's one or both eyes. So sometimes patients may have a mild cataract and actually their other eye is fully functioning and they're fine with that, and that's okay. Of course, you know, you talk about surgery, you know, which is kind of normally, you know, done under the specialists, tiny cut, small, the cataract is removed and an artificial lens is put in, and afterwards actually their vision tends to improve quite a lot and they can go back to doing their normal day-to-day activities. And of course, you know, like we said, for babies and children, you know, it's just an urgent referral to the ophthalmologist because they need to treat that as soon as possible. So adults have the opportunity, depending on what effect it's having on their life, and then they get referred for the surgery. The important thing, very important for you guys to remember, is we need our eyes, obviously, to drive. And this is the baseline thing. This is the thing that you should remember. This is a classic AKT question. But basically, the DVLA says that a person has to meet the following standards. So in good daylight, you need to be able to read a modern vehicle number plate at a distance of 20 meters. So 20 meters is the take-home distance that you need to be mindful of. And the visual acuity must be at least 6/12 with both eyes open, or in only one eye if they've only got one eye vision. If you cannot meet that criteria, then the DVLA must be notified, and they will make the next decision. But being more specific, so you know, you've got people who, for example, are group 2 drivers, so the bus drivers and the lorry drivers, they need to have a higher standard of visual acuity. So you'll look at the figures and they have to be much more tighter for this group. You know, so they need to have at least, you know, and that's corrective contact lenses if need be, a Snellen of 6/75 in their good eye or 6/60 in the poorer eye. And again, we often send them to the ophthalmologist, you know, because they're probably going to be better at doing this than we would, or the opticians rather than we will. But it's important that you just know that the key thing here is that it's a higher, much stricter criteria for group 2 drivers. If the cataract patient cannot meet that criteria, they will have to inform the DVLA. But remember, sometimes the cataract may not be that bad, and actually they can read a registration plate from, you know, 20 meters, and they get a good score on the Snellen chart, in which case they don't have to. So if it's an issue, we notify the DVLA. If there's any uncertainty, or they're not sure, or you're not sure, you can always still get the DVLA on board for advice. They do have a medical team that can offer advice. And from our side, it's important that we document any advice given. Worst thing could be you know, they carry on driving and you gave them permission, and then they have an accident that causes injury to them or to somebody else. That is your whistle-stop tour of cataracts. Obviously, you know, we're on social media. If you're not doing so already, do follow us on the following platforms: the Instagram Inspire_Medics page, lots of different things. So YouTube Inspire Medics, Twitter Inspire Medics. We've got the AKT Facebook page, which I think many of you will already be part of. So do obviously join that as well for updates. If there's any questions, do let us know, and I will post some of the links in as well.
So guys, whilst we're waiting for the questions to come up, just a couple of things. You know, our AKT question bank and the MSRA question bank they're both free. Me and Dr. Sandhu spent 3.5 years almost building that question bank, and we decided not to charge for it. I mean, I know we charge for other products like the Gold Package and the RCA Communication Skills course. For that's like a core product that most trainees need. We haven't charged because it's like a barrier to entry. Like, you want to subscribe to 1, 2, and then you don't want to subscribe to a third one because it costs too much money. So if you don't mind, and also we do these free webinars, if you don't mind, could you kindly just leave us a Google review? I've included the link in the chat. So if you scroll up before Dr. Sandhu's URLs that he's put in for the social media. Just click on it. It literally takes 20 seconds. You go down to Inspire Medics Limited, leave a review, and you just type in hopefully a nice review, if that's okay. Whether it's the free webinar that you appreciate, whether it's the free AKT question bank that you appreciate, because at the moment we have worked really, really hard on that question bank. We are planning to keep it free forever, as we have done for MSRA and the PLAB exams, and we're just going to build it and build it and build it. And we're adding some amazing features to it. So we've got the gamification feature, the search feature, we've got the AI technology working in the background, and the more people that start using it, well, I mean, we pay more for our server costs, but at the end of the day, we want to provide you with some amazing value, no matter what stage of your career you're in. So if you wouldn't mind kindly just taking 20 seconds out your day, about 60 seconds perhaps at the most, clicking on that link, which is the link I've included for the G page Inspire Medics, and then leaving us a review. I think Dr. Sandy is going to mention a couple of things about the forum and perhaps the social media challenges before we wrap up.
Yeah, absolutely. So very quick overview, guys. So just remember, we have got a brand new forum, which is on the website here. So if you click over here, and it's broken down into different things, different strands. So for example, the MSRA GP entry exam, GP exams, you simply click it and it will break down into different topics, AKT, RCA, CSA, and so forth. This is a brand new forum. It's on the website. It's free to use. It will be a good way to connect GP trainees and doctors across the country, as well as, of course, doctors across the world. As you know, we're involved in international medical education as well for the PLAB doctors who want to work in the UK. So this has only just been launched, so don't be alarmed by the fact that there's not much there. It's literally just been released, but it is for you guys. So use it if there's any questions that you have. And there's lots of things. There's jobs and careers, there's finances and tax, you know, case discussions. You can use it as part of your CPD when you qualify as GPs, as well as, of course, your current GP program. We've got lots of other things, business opportunities that you might be interested in, the incubator program, social life, current affairs, you know, lots of different things. That it's a forum, you can post in there, and you're likely to get somebody who will give you some information and tips and advice. So that's the first thing. The second thing, of course, is the blog. So do remember that we've got these blog sections up here. The doctor blogs are very good because they give you both clinical information as well as information that you can use for explanations for your patients on a day-to-day basis. So little things, you know, you've got your clinical trial stuff, relevant articles like, you know, how to stop procrastination. And then we've got other things as well, like acute asthma. I always use these kind of things. Here's one in children, very useful revision and easy to digest and follow. So look, you can kind of have a look at some of the key parameters and you can see the learning. It's very straightforward. It's color coordinated. It's bullet pointed, easy to use for your revision, for your learning, simple to find. It's in the blog section. If you go on the patient information section, you can signpost your patients here as well. For example, if you've got someone with psoriasis, you can say, have a look at this, Mrs. Smith. Mrs. Smith will be happy because it's 60 seconds and she learns about psoriasis. But from your side, it's very important for the RCA and in your day-to-day general practice that you can explain a condition like psoriasis in simple language so that your patients will understand it. And you can see how easy it is to follow. So that's up here. So remember, you've got blogs, doctor blogs, and patient information. You've got the forum here. And a couple of bits as well. We've got a couple of good products that people kind of like. So we've just summarized these things for your doctor's bags. If there are things that you're looking for, some recommendations. It's not bought from us, by the way. These are from, you click it and it will open up in Amazon, but there's some good products in the shops that people are using at the moment in day-to-day medical practice. So nothing specific otherwise to add. I think you've probably seen us on our YouTube page. If you haven't done, make sure you do subscribe and follow. It looks like this. You can see the webinars back as many times as you want. You can see some revision videos and the list is endless, and there will be some more content going up on there. I'm sure you'll have our Twitter and Instagram as well. So inspire_medics, cluster headache, just little things like this, which doctors find very useful for their revision. Shingles, current NICE guidance, diagnosis, management. Use that. It's all on our social media. And of course, it's there for your learning.
Absolutely, guys. And don't forget the big AKT mock tomorrow. It's starting at, if I've got the time right, 10 a.m. and it finishes about 7 p.m. 1 hour lunch break in between. amazing value for money. You will learn so much. And if you, I can see a couple of you added it to your cart, but you're not sure, this checkout is going to be one of the best decisions you've ever made. And then finally, we hope to see you soon. We're going to send you out a link for the recording of this webinar and also an invitation for the next webinar. Please do let your friends know about us and your colleagues. We were both GP registrars a few years ago, so we know exactly what it's like to be on your side. Nervousness, you know, anxiety about passing the exam, and then the RCA, and then obviously becoming specialists in your fields. And the COVID pandemic certainly hasn't helped, and it's made things so much more stressful. So wherever you are in the country or the world, please do stay safe. Hope your families are safe as well. I'm sure we're going to see you soon. And don't forget, guys, to leave us a Google review. I think, have any of you guys got any questions before we wrap up for the cataract side of things? Otherwise, we'll pretty much wrap up from here. I don't think. Brian, thank you for the comments. Thank you for joining us once more. It's always good to see a familiar face. And it was yourself who put in a review. That's amazing. We've got, like, I think we do have lots of reviews on Amazon. Sorry, not Amazon, on Google. But if you can kindly just leave us one, it'll take you literally 20, 30 seconds to do. And the link is down there in the chat box before we go. So guys, take care. We'll see you soon in about 2 weeks' time. And keep an eye out for our emails. Don't unsubscribe to those, because I know they can sometimes get a bit annoying, but we do release lots of useful information in those emails, new product launches, new features, like new amazing opportunities. And then, of course, the last thing to add is we've got a jobs platform called Medic Flow, but that'll probably be another day that we mention it to you rather than today. So thank you all. Take care, stay safe, and we'll see you soon. Oh, Farron's going to see us in an hour's time. Fine.